You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
Clozapine, the gold standard that comes with homework. Clozapine is the only antipsychotic proven effective for treatment-resistant schizophrenia and is FDA approved for reducing suicidal behavior in schizophrenia/schizoaffective disorder, but it comes with serious monitoring requirements. Think of Clozapine as the most powerful tool in your toolbox, but one that requires a license, safety goggles, and regular inspections to use. FDA-approved indications. Know these. Treatment-resistant schizophrenia failed greater than or equal to 2 adequate antipsychotic trials. Reducing recurrent suicidal behavior in schizophrenia or schizoaffective disorder, possibly persistent aggressive behavior in schizophrenia, off-label but guideline-supported, the Clozapine REMS program, the 3 must register rule. REMS equals risk evaluation and mitigation strategy, a mandatory FDA safety program. 3 parties must be registered before a single pill is dispensed. Prescriber must complete certification, education plus knowledge assessment. Pharmacy must be certified to dispense Clozapine patient, must be enrolled in the REMS program Memory Trick. 3 Ps must be in REMS. Prescriber, pharmacy, patient. Before the first dose can be dispensed, obtain a baseline ANC, absolute neutrophil count. Report the ANC to the REMS program. ANC must be within range before prescribing and dispensing. The REMS exists because of one main risk: severe neutropenia/agranulocytosis. ANC monitoring schedule, the timeline you must memorize. Memory trick: 6-6 forever equals weekly 6 months to bi-weekly 6 months to monthly, forever time period ANC. Monitoring frequency, memory cue, months 1 to 6. Weekly new relationship equals check-in every week. Months 7 to 12, every 2 weeks. Getting comfortable equals every other week. Month 13 plus monthly. Stable equals monthly check-ins forever. All ANC results must be reported to the REMS program. No report equals no refill. ANC thresholds, the traffic light system. General population, no BEN. ANC level status action, greater than or equal to 1,500 per microliter. Normal continue Clozapine. Maintain scheduled monitoring 1,000 to 1,499 per microliter mild neutropenia. Continue Clozapine. Increase monitoring to 3 times per week until ANC returns to normal 500 to 999 per microliter. Moderate neutropenia. Stop Clozapine. Hematology consult recommended. Daily ANC. May resume once ANC greater than or equal to 1,000 per microliter, less than 500 per microliter. Severe neutropenia, agranulocytosis. Discontinue Clozapine. Daily ANC. Hematology consult. Do not rechallenge unless benefits clearly outweigh risks. Benign ethnic neutropenia, BEN. Thresholds lowered by 500 per microliter. ANC level status action greater than or equal to 1,000 per microliter. Normal for BEN. Continue Clozapine 500 to 999 per microliter. Mild neutropenia, BEN. Continue Clozapine. No increased monitoring needed for BEN. Less than 500 per microliter severe neutropenia, BEN. Stop Clozapine. Daily ANC. Hematology consult. Key BEN facts. BEN equals naturally lower neutrophil counts. not increased infection risk. Affects up to 1/3 of individuals of African or Middle Eastern descent. BEN is a diagnosis of exclusion. Should be confirmed by a hematologist. Requires at least 2 baseline ANC levels before starting clozapine. Minimum ANC to start clozapine in BEN. Greater than or equal to 1,000 per microliter versus greater than or equal to 1,500 per microliter general population. Memory trick for initiation thresholds. 15 for general, 10 for BEN. Times 100 equals 1,500 and 1,000. Dosing and titration. Start low, go slow. Phase dosing. Key point. Day 1, 12.5 milligrams once or twice daily. Ultra low. Start to prevent orthostatic hypertension. Days 2 to 14. Increase by 25 to 50 milligrams per day. Target 150 to 225 milligrams twice daily by end of week 2. After week 2, increase by up to 100 milligrams once or twice weekly. Titrate to clinical response. Target dose 300 to 450 milligrams per day. Most patients respond in this range. Maximum dose 900 milligrams per day. 450 milligrams twice daily. Rarely needed, the 48-hour rule. If clozapine is missed for greater than or equal to 48 hours, then must restart from 12.5 milligrams and retitrate. Missed 1 day, then resume at 40 to 50% of previous dose. Missed 2 days, then resume at approximately 25% of previous dose. Missed greater than 2 days. Restart at 12.5 milligrams. Why? Risk of severe orthostatic hypertension, bradycardia and syncope with re-exposure. Therapeutic drug monitoring, TDM. Target clozapine plasma level. Greater than or equal to 350 nanograms per milliliter. Optimal cutoff for response. Recommended range, 250 to 550 nanograms per milliliter. If no response at 350 nanograms per milliliter, then increase dose to achieve levels up to 600 nanograms per milliliter if tolerated. Check levels during titration at 300 milligrams per day for suspected non-adherence or drug interactions. Memory trick, 350 is the floor for response. The big adverse effects. Organized by system hematologic, the reason REMS exists. Agranulocytosis, ANC less than 500 per microliter. Approximately 0.7% prevalence. Potentially fatal risk is highest in first 18 weeks, then drops to background rate not dose-dependent. Can happen at any dose. Signs: high fever, lethargy, sore throat, mucosal ulcers, throat, perianal, genital. Neutropenia is not the same as agranulocytosis. Neutropenia is milder cardiac. The silent dangers. Adverse effect: monitoring action, myocarditis, troponin plus CRP at baseline, then weak.
Thanks for watching. Like and subscribe for more content.